Started. Welcome everyone to the Stanford Medicine Center for Improvement Lecture Series. I'm Laura Holdsworth from the Evaluation Sciences Unit in the Department of Medicine. And it's my honor to facilitate today's lecture with Sarah Gilman. Just before we get started, just a couple quick announcements. Firstly, I just wanted to take a moment to recognize the shooting that took place yesterday in Half Moon Bay, really because it has directly impacted our Stanford community. And I just wanted to sort of echo the sentiments that Dean Miner and company emailed about earlier today, and also really to express gratitude to those of you working in the hospital to care for the victims, and all of you really for being here today. So thank you so much for taking the time to join our lecture today. So now for some SMCI announcements. The winners of the 3rd Annual Excellence in Improvement Publication Award will be announced next month. For those of you not familiar with the competition, authors from the Stanford community are encouraged to submit articles in November published in the previous academic year that focus on health services and/or quality improvement. I think there were 48 submissions this year, and I believe there will be 4 winners selected. And of course, we would love to have those winners present their work at this lunchtime series in the spring or summer. So you'll expect an email. Lastly, our next lecture will be on February 14th with Nigam Shah, who will be talking about his perspective as the SHC Chief Data Scientist. And so we hope you all can join us for that session. So that's all of the announcements I have. So now I'd like to introduce today's speaker, Sarah Gilman. Sarah is the founder and principal consultant at Wayfinder Health Strategies, which is a federally certified woman-owned small business in Washington, D.C. She specializes in health communications, program development, and public health research. She's worked with a variety of organizations, including the U.S. Agency for International Development, the Bill and Melinda Gates Foundation, and the CDC. She has a Master of Public Health, is a certified health education specialist, and is currently a doctoral student at George Washington University in the Translational Health Sciences program. As usual, if you have any questions, you can go ahead and put them in the chat, which I'll monitor. If it's okay with Sarah, I'll interrupt if there are any questions to clarify any points. Otherwise, I'll just keep track of them for our discussion at the end. So we'll aim for about a 30-minute lecture, and we'll have some time at the end for questions, and we'll try to wrap up about 10 minutes before the hour, so everyone can have a bit of a break in their day. And with that, I will hand over to you, Sarah.
All right, great. Thank you so much, Laura. Well, good afternoon, everyone, and thank you again for the invitation to be here today. It really is a pleasure for me to be here, and I'm so excited to tell you a bit more about the Learning Health Systems Toolkit. I hope that you'll find this resource to be a helpful addition to your arsenal, and I'm also really looking forward to the opportunity to learn a little bit more about what your own experience has been developing a learning health system at Stanford. Because in addition to sharing the toolkit with you, I'm also hoping that we can identify some additional improvements and additions that we could make to the toolkit based on your experiences and on our conversation here today. This toolkit is the result of an international and a multi-institutional collaboration of learning health system experts. And as Laura mentioned, I'm a PhD student in GW's Translational Health Sciences department. So over the past year and a half, I've had the privilege of being able to help develop the toolkit. The names of those who participated and the institutions who participated in this toolkit working group are listed on the slide, as you can see, so are the logos for each of the institutions. And I'll just say that for me, working on this project was a really wonderful example of what team science is. It was really neat to be learning about team science, but also to be observing this international collaborative of scientists who are all working together towards this common goal. So, of course, we're very grateful to all of these individuals and institutions for their support in building the toolkit. And as you might suspect, we now have a beta version of the toolkit that's available online, and which I'm going to be showing you today. And we're really excited to be able to launch it to learning communities who are building learning health systems. And we're also really excited to get feedback on the toolkit so that we can continue to optimize the toolkit into the future. The aim of the LHS toolkit is to amplify and accelerate the positive impact of learning health systems. And it aims to do this by supporting learning communities that want to improve their systems of care as they develop, implement, and then sustain a learning health system. So today, what I would like to do is to tell you a little bit more about the toolkit by first describing the importance of learning communities in a learning health system and talking a little bit more about how the LHS toolkit meets the needs of these communities. And then I'll detail our development process and as we worked on the toolkit and what some of our next steps for the toolkit are as well. And I'll just end by providing some information for you to be able to use and contribute your own tools to the toolkit. And what you see here on this slide is a screenshot of the homepage of the LHS toolkit. And we'll also go through several screenshots that explore the toolkit and some of its features. And I'll just start by saying that this is a really exciting time for us to launch an LHS toolkit, given the fact that since 2007, when the Institute of Medicine coined the term learning healthcare system, an interest in learning health systems has really grown both rapidly and steadily. And LHSs, as you know, are increasingly being proposed to improve care delivery through the confluence of science, informatics, incentives, and culture. But as you also likely know, developing a learning health system, even though extremely rewarding, is also very complex and can at times be challenging as well. And part of the reason for this is that no learning health system is exactly like another. And so there really can't be a tried and true one recipe for building a learning health system. But there are unique elements that we know are defining elements of learning health systems. And one of these elements is the learning cycle of learning health systems over here on the bottom left of my screen. And this is where clinical practice yields data that can then be explored and synthesized into actionable knowledge, which then in turn iteratively continues to improve practice. Another key and defining element of learning health systems is the learning community, without which a learning health system simply could not exist. So oops, sorry about that, lost my slide. So a learning community drives the learning cycles that are necessary for a learning health system to emerge. We can think of a learning community as a group of committed stakeholders who collaborate and cooperate to be able to achieve collective improvement. And we can also think of them as serving somewhat as an engine that directs the learning cycles from the acquisition and analysis of data to the development of new knowledge, and through new and actionable knowledge back to the improvement of practice, which obviously then produces new data and enables us to continue to improve in a continuous and enduring way. And to quote Drs. Foley and Vail, a learning community is a group of stakeholders who come together to achieve collective improvement. And as Dr. Chuck Friedman has laid out in his visualization of a learning health cycle, members of a learning community are driven by a shared passion to improve against the health problem that brought them together. That same group directs the cycle through the sequence of discovery, implementation, and back to discovery again as the cycle continues. So within a learning cycle, we might see a learning community depicted at the center of the learning cycle, or we might see them depicted as a necessary part of the flow of a learning cycle. But regardless of how learning communities are depicted, it's clear that they are really an integral part of a learning health system. And we know that learning health systems, depending on their scale, can also have, and usually do have, multiple learning cycles that inform them. And each of these learning cycles is driven by a committed learning community. So as you can imagine, when we actually think about real world learning communities, they're quite a bit more complex than what we're observing in these three models on these slides. And this is partly because learning communities are composed of stakeholders who usually operate at multiple levels of an organization or multiple levels of a system. So for example, members of a learning community might consist of patient representatives, clinicians, researchers, executives, to name a few individuals. And also, since one learning health system will likely have multiple cycles that operate at the same time, there might be learning communities that are oriented around different health problems of interest. So they might be operating not only simultaneously, but also at different levels. So they might be at the level of a team, an organization, or even a multi-institution or national collaborative. So they can be quite simple or they can be quite complex. The take home is really that you can't have a learning cycle without a learning community, and you can't have a learning health system without one or usually more learning cycles. I'll just end by saying that one of the things that is certain about learning communities is that they need a supportive, like most people who are involved in most projects, they need a supportive infrastructure. They need psychological safety, encouragement, and the tools necessary for them to be able to do their best work. So, of all the different ways that we could support learning communities, why would we build a toolkit? Well, one of the most important reasons for building the toolkit is for us to be able to provide learning communities with a library of resources that will be able to provide the support and the tools that they need to be able to address barriers and also capitalize on opportunities in their context. So our hope is that providing learning communities with a menu of support or support tools and resources might be helpful and might help these learning communities to close the evidence to practice gap better, faster, and in a more replicable way. And also to close this gap in a way that permits learning communities all over the world to share knowledge with each other. And I think that part is probably the most important part of the toolkit. We designed the toolkit so that learning communities can not only access tools, but can also add tools and resources that have worked for them on the toolkit. And so hopefully this will amplify any positive impacts that any one learning community is finding. And since every learning health system is different resources or tools will be useful in different systems or different contexts. So different challenges might have multiple avenues through which you can approach a solution, and thus different tools might serve for different situations. So in this case, a wide library of tools and resources that learning communities can pick and choose from is really optimal. I'll end my explanation of why the toolkit might be a useful solution for learning communities by highlighting the results of a question on a survey, which was conducted last year by the Health Foundation in the UK. And the Health Foundation is a nonprofit that aims to improve quality and equity in healthcare. And they conducted an online survey, a small online survey of 109 UK stakeholders who had specialized expertise in learning health systems. And one of the themes that they asked about was regarding the biggest improvement challenges for developing and scaling learning health systems. And admittedly, this is a really different context and an entirely different national health system. But I think that many of the improvement challenges that are listed are also ones that I've heard and maybe you've heard discussed in the context of building a learning health system. And, lack of capacity, for instance, tops the list, followed by lack of financial and other support, an existing gap between healthcare research and practice, lack of skills and knowledge, absence of evidence about learning health systems, and absence of a culture of learning and improvement. And we can certainly see how having a toolkit with really concrete and tangible tools might fill a gap in terms of lack of skills and knowledge. But I think we could even go a step further, and we could argue that having access to specific tools and specific sources of knowledge could help at least partially with all of these challenges that have been identified. And this might be especially true and especially useful if the resources that are shared are resources that had already been tested and shared by other learning communities in other learning health systems. So hopefully I've done a good job of making a case for why the toolkit was designed, but let's turn our attention now to the actual methodology behind the development of the toolkit. The structure that informs the toolkit was based on a learning health systems framework that was developed by Drs. Tom Foley and Luke Vail and published recently in 2022 in the Learning Health Systems Journal. And this framework builds on the work of other learning health system experts, and it also draws on fields like implementation science, complexity science, and quality improvement. So at the center of the framework, you won't be surprised to see the learning health system cycle. But we also have several additional components to consider in terms of understanding, designing, developing, and evaluating learning health systems. And this brings in the idea that every learning health system is unique, and there are a lot of different considerations for learning health systems beyond the learning cycle that the learning health systems are engaged in. So for example, a learning health system might vary by the rationale for building a learning health system. It might vary by complexity. It may vary by the kind of change that is being targeted by that learning health system. And it might vary by the system level that the learning health system is operating at. So whether that's local, regional, national, or international. So this was a helpful framework to inform the way that we went about structuring not only the toolkit, but more importantly, the tools and the variety of tools that would go into the toolkit. And this chart depicts our process in terms of populating the tools into the toolkit. We first developed inclusion criteria for the tools in the toolkit. And then we populated the toolkit with tools using an interdisciplinary and team-based approach. And then steering group members provided review and recommendations on the initial resources to be included, followed by multiple rounds of feedback and quarterly review and approval of any newly added tools. One thing that worked really well for us was that we had a standing monthly meeting as a group. And so it was quite easy to go through multiple rounds of feedback for the toolkit. And it was also easy for us to be able to field a digital survey to various members of the working group who had expertise in learning health systems, and to get some good initial feedback on the beta version of the toolkit. And this feedback that they provided ultimately contributed to the modification of our inclusion criteria, as well as to recommendations from new tools. We did include several resources, and you'll get a sense of the breadth in the toolkit in a moment. And the resources that we drew from are case studies, peer-reviewed articles, reports, methods papers, as well as organizational websites. We've also found it really helpful to develop governance guidelines for the toolkit. These guidelines govern a variety of things, but they govern our guidelines for managing content, for roles and responsibilities on the team, review and approval practices for any tools that are submitted to the toolkit. And we also created a monitored email address in order to facilitate communication with toolkit users and to collect feedback on the toolkit. And I'll list this again at the end of the slide deck, but for now, I'll just say, please do feel free to reach out to us here at this email address with any questions or any thoughts that come up. And in terms of collecting early feedback, we also added some links to a short evaluation questionnaire in the toolkit. And we also added a link to an evaluation questionnaire in an automatic confirmation email that users receive when they submit a tool. So if you were to submit a tool, you would be asked to complete a short-term survey, optional survey, when you receive a confirmation email. We do expect to continue to build on our evaluation work with the toolkit by conducting a more in-depth evaluation in the future. But for now, we've included the link in the toolkit and the confirmation email so we can capture any immediate feedback as we launch this beta version. To date, we've added more than 70 tools to the toolkit, but we're certainly still actively adding to and improving upon these tools. The tools that have been included to date have drawn from fields like implementation science, quality improvement, complexity science, systems thinking, value-based healthcare, informatics, and team science. So you can see it's quite interdisciplinary in its focus. And this is a screenshot of the current homepage for the toolkit. As you can see, the toolkit has 3 key sections. Find a tool helps users identify helpful resources according to their goals. All tools allows users to peruse all the tools and pick and choose what works best for them. And submit a tool is, to us, the most important section, because this is where we hope that others will add to the toolkit and hopefully increase the impact of the toolkit through knowledge sharing with other learning communities. This is a screenshot of the Find a Tool page. You can search for tools by objective here. For example, find tools for developing the technical building blocks of a learning health system. But if you have a good sense of what you're looking for, then you can also do a keyword search for a tool. And here, I want to quickly just walk you through some of the major sections of the toolkit. These sections are organized by objective. So depending on whether you want to find tools to clarify why you need a learning health system, or develop technical building blocks, or understand sources of complexity and failure in your learning health system, or find tools to help you understand and manage strategic issues within your learning health system. If, for example, you wanted to find tools for developing the technical building blocks of a learning health system, you also have the option to then drill down a little bit further and get some suggestions in terms of looking at tools based on whether you're looking to generate data from existing practice, or generating knowledge from that data, or putting knowledge into practice, or whether you're looking for tools to provide support around technology platform tools. And likewise, we have various subcategories under understanding the sources of complexity and failure in your LHS. And this includes things like tools for thinking about the complexity of your technology, tools for thinking about how your LHS may adapt over time. And under tools to help understand and manage strategic issues within LHS, users can select from strategy tools, to implementation science tools, to co-design tools, or evaluation tools. And this is simply a screenshot of our all tools section of the toolkit, which is helpful if you want to get a general sense of all of the tools that the toolkit has to offer at the same time. I would say at the moment we have about 70 tools, so I definitely recommend going in and looking over this section. As the toolkit continues to grow, you might want to take a bit of a more targeted approach. So zooming in a little bit, I want to just take a minute and show some of the selected tools that are in the toolkit, just to give you a sense of the kinds of tools that are in there, but also the breadth of tools. This is a case study of the Nightingale Learning System in the United Kingdom that emerged in the context of the COVID-19 pandemic. And the NHS in England turned a London Convention Centre into the first of the country's Nightingale hospitals. And by doing so, by creating these Nightingale hospitals, dramatically expanding treatment capacity. So far, we've seen the same thing in our health system. What is unique about this case study is that in this rapidly changing environment, they also managed to build in a learning system into the organizational architecture of the facility. And so in this case study, they report out how they developed this structure in order to be able to optimize rapid and continuous learning, which, of course, given the context, was built around the need to learn things both quickly and efficiently in a context where there are multiple unknown factors. And I include this case study and we've included other case studies as well, because often using a story about another organization's experience in learning health systems can be a useful way of being able to clarify what experiences or lessons learned may or may not be shared between different learning health systems, or how your learning health system might be different and unique from this one. What actions, tangible actions that you can take or draw from the case study to move forward, and also who you can connect with to learn more. This is another potentially useful tool in the toolkit. I think many of you on the call will recognize it. This is the Consolidated Framework for Implementation Research, or CFIR. And I include it here just to demonstrate how we can draw on implementation science in the design and implementation of learning health systems. So for anyone who would like to learn a little bit more about CFIR, CFIR is an implementation science determinants framework that is based on implementation constructs from 19 different frameworks and theories and a review of 500 published sources across 13 disciplines. So it has a really strong evidence base, and it's used widely to plan and assess innovations or interventions or programs. And it's really helpful when implementing or evaluating a new intervention or a new program, to be able to use a determinant framework like this one to be able to think about what works and what does not work from the perspective of the different components of the framework. This tool is a tool regarding network maturity grids. Well, in learning health system, maturity refers to the degree to which a particular practice or a particular process is able to help us achieve a specific outcome. And the network maturity grid is specifically oriented around learning health systems. And it's a maturity assessment that helps us understand or benchmark the maturity of a learning network. Building a learning health system, as we know, takes time. So it's always helpful to have something that we can use to measure the development of our learning networks and our learning health system. And one thing that I really like about this tool is that it can also be used to generate self-assessments. And of course, it describes the ideal processes needed for learning network operations and for strategic planning. And although this is quite far outside my area of expertise, I wanted to show one of the resources on the data side of the toolkit, because we did have, as I mentioned before, quite an interdisciplinary team and an interdisciplinary approach to developing the toolkit. Data interoperability, for those who don't know, and relates to the ability to be able to safely and effectively exchange data between different systems and organizations. So this is, as you can imagine, a task which is often easier said than done. And this is a tool that, like the network maturity grid, enables stakeholders to be able to assess their progress, except in this case, they're assessing progress towards data interoperability. And like the prior tool, it can be used to develop self-assessments or to identify gaps in interoperability maturity or to plan improvements. And this is the last tool I showed you. This is a guide to build co-design capabilities, which I find extremely helpful, because co-design is a key element of any well-functioning learning health system. And it really allows us to be able to approach a health problem from multiple perspectives. In the case of this particular tool, the perspectives that it draws from are patient perspectives, but I think you could really use this tool to do almost any kind of co-design. Finally, this is a screenshot of the Submit a Tool page, which, as I've mentioned before, is arguably the most impactful page in the toolkit, because we hope that other implementers and researchers will use this page to submit tools and case studies and other resources that have been helpful to them. In order to submit a tool, a user just needs to provide a username and an email, give a short title for the tool, a short description, and either a link or a PDF to the tool, although we prefer a link. We also ask that you indicate some preliminary subject categories. I won't go through all of these, but just to give you an idea of some of the categories that we suggest. So you just pick from these categories and it'll give us a sense of where in the toolkit these tools would live. In terms of next steps for the toolkit, at the moment, our highest priority is still adding new tools to the toolkit. And one way that we plan to do this is by continuing to engage learning health system experts and learning communities who are interested in testing and adding tools to the toolkit, as well as recommending tools for us to be able to add to the toolkit. We are also currently developing a dissemination plan and an evaluation plan for the toolkit. And that will be really key, I think, as well. We also have some really exciting news. We're delighted to report that late last year, we received funding from the Health Foundation to continue to optimize and disseminate the toolkit. And this funding, it will enable us to continue to make some really great progress. Certainly, we'll continue adding to the toolkit. We'll also be able to do some additional work in terms of collecting user feedback. And it will also allow us to continue developing evaluation and dissemination plans and to implement these plans as well. We will then plan to build on the feedback that we collect by developing a second improved iteration of the toolkit, and we expect to launch the second improved iteration of the toolkit in the second half of this year. As I stated at the beginning of the talk, the aim of the toolkit is to amplify and accelerate the positive impact of learning health systems. And we hope to do this by providing the knowledge and the tools that learning communities need to do their best work. And our hope is that this will result in more connected and more knowledgeable learning communities and ultimately in improved systems of care. So to close, I'll say that ultimately the potential impact of the toolkit, regardless of its aim, really depends on the contributions that are made by stakeholders such as yourselves. So please do share your expertise, your lessons learned, the tools that have helped you, share all of these with us. We would love to hear your experiences developing a learning health system. And I think it would even be helpful to understand what questions and challenges are coming up for you so that we can consider what resources might be most helpful to add to the toolkit to address some of these challenges. I would love to learn a little bit more about what Stanford's experience has been with the development of a learning health system in terms of what has gone well. How is the learning health system working across multiple levels of your system? What barriers have you encountered? And what technical or strategic levers have helped you make progress? All of this helps us develop and improve upon the toolkit and helps us root the toolkit in real world experiences. And if you have any suggestions on how we might go about engaging implementers to have them contribute tools to the toolkit, that would certainly be appreciated as well. We know that as we saw from the Health Foundation's survey, capacity can be a real challenge when we're trying to create a learning health system. And we're sensitive to the lift that we're asking people to make by contributing to the toolkit. So we would certainly love to hear any suggestions about how we can lighten that lift for others as well. As you can see, I've included a link to the toolkit here, and please also feel free to email us anytime at the email address on this slide. I've included the link as well here. If you'd like to reach out to me personally, please don't hesitate to do so. I've included my email address and my Twitter handle on this slide as well. Thank you so much. And I'll just leave this up for a few extra seconds to give everybody a chance if they want to jot down the link.
Thank you, Sarah. Round of applause. I'm sure everybody will join in a virtual, which is a little kind of sad in the post-pandemic world where you can't actually hear the clapping. But thank you so much. That was wonderful. And it was so nice. I first heard about this at the Dissemination and Implementation conference in Washington, D.C. in December. It was so nice to have more information about it. I think there's a question in the chat, but I'm going to take the opportunity to start with one of my own, which you just finished talking about, asking for additional tools. And I was just wondering, which hopefully a lot of people on this call, you will have reached a wide audience of people who might have things that they would be able to add. I'm just wondering what your process is for sort of vetting. You talked about the tools that are in there. You went through a process, and I'm just wondering what your process is for things that are offered on the websites, and how, what you'll do with those.
Our process for vetting tools,
new and suggested ones,
ones that are submitted. This is something that we've spent a lot of time thinking about and working into our governance guidelines, because we want to make sure that we can guarantee that the tools that are on the toolkit are evidence-based, or at least helpful, to other learning communities. We have arrived at somewhat of a two-phase process for doing this. So we have a first layer of review that happens pretty much as soon as the tool gets submitted to the toolkit, or within a couple days of submission. And that is usually done by a PhD student at GW, one of a team of PhD students at GW who are translational health science, whose focus is translational health science. The purpose of that review is just to say, this, I can vouch for this tool. This tool is not, we know this looks good to us. We think this is a good potential tool for inclusion. But there's a second layer of review from there that really is from our learning health system experts in the Toolkit working group. And it's at that point that the student collates on a quarterly basis, however many tools have been submitted, splits them up amongst the members of the working group. And then each member of the working group has to review each tool one by one against the criteria that we've developed. And the criteria is pretty standard. I would say the review is generally just to ensure that it's evidence-based and trustworthy, that we know who's sending it, and that we're allowed to be able to share that tool. And most of the time, or at least with the 70 tools that are on now, the tools have been all very recognizable to all of the experts in the working group. So we haven't had anything stump them quite yet.
Okay, great. I think in the chat, and everyone, feel free to put your questions in the chat or raise your hand, and I think you'll pop up and I can call on you. I think there's a question from, is it Elena Kipps? How much has the Anderson Center collaborated with you? It's the best known pediatric network of learning networks, and we have learned quite a bit with their support about running various pediatric cardiology collaboratives. So I guess the question is, have you worked with them in developing this?
We haven't worked with them in developing this. We are aware of the fantastic work that they're doing, but we haven't had the opportunity to work one-on-one with them in terms of this toolkit. And I think that would be a really great partnership for us to be able to pursue, if nothing else, as a case study.
Yeah. Okay, great.
With some of the quality people within the Anderson Center, because I agree. I mean, they have a ton of resources, and some will overlap with what you've already presented, but others may be like a repository. In my experience, they're extremely willing to share things, so it may just accelerate getting those other toolkits or subsections that you're desiring at this point of the build.
Fantastic. And that fits right in with our goal, which is at this point to really, in terms of our dissemination, to reach out to learning health systems and learning health system experts and really ask them what's been useful for you, and what's your experience been. So that would be fantastic. Thank you for that suggestion. Appreciate it.
There's also a question from Lisa Freeman about whether the VA has participated as well.
Not yet, but again, that's a fantastic suggestion. We'll be sure to add that to our list.
Great. I had another question about whether you're going to collect any information on the tools that get used. So what are people who use it? What are they using? Maybe what they're using it for, what their experience is, and sort of like a feedback loop, if you will, just to kind of map, what are the things that people are using. I know, certainly we've used CFR before. I think a lot of people use that, but I had to look previously, and there's a lot of things on there. I just was wondering if you're tracking in any way, finding out what's being used.
Yeah, I think at the moment, what we're tracking is either analytics or user feedback directly, but we haven't closed that loop and seen, once people have access to a particular tool, what are they using that tool for? How did the process go? Did it work out? So I think that, that's a great suggestion. And we are, as I mentioned, in the process of developing an evaluation plan. Once the funding from the Health Foundation comes through, we should be able to build on that a lot more. And so I think this is a really great thought to be able to follow up on as we start to build the evaluation more.
Yeah, great. And it looks like another comment from Lisa. I think there a lot of the questions you had at the end, Sarah, about experience at Stanford. I feel like Lisa's going to be a really good informant for you. That she mentioned Alpha Bias and the patient experience team are making sure that they're aware of the tool. Is that right, Lisa? I don't know if there's anything.
Especially the co-design, because we use in our advanced course. We've had the consultant that she employs teach in our advanced course, and definitely will add this tool to the curriculum when we give students resources from ACES. So really happy to know about this.
That's great. Thank you, Lisa. And I'll just add that the co-design section of the toolkit probably has even more tools that could be accessed, but we're still adding on to it. So do have them come back over time as well. Because I'm certain that we will have more co-design resources on there as well. Great.
And I think Margaret Wang added a suggestion for the previous comments about, how are you going to track use over time? So she said IHI and ICHOM ask people who want to download documents to provide the email and organization affiliation. I think I've encountered that with like some of the normalization process theory stuff too, where they, in order to get it, it's free, but they want to know who you are, so they can track it. So that could be one way to kind of add that to your evaluation and maybe follow up with people.
Yeah, we do request email and organizational affiliation, but at the moment, and this is something that other members of the working committee may be aware of, and I may not be. At the moment, I'm not sure whether we link between the name and email and what tool someone's downloaded and how they've used it. So that would be interesting to find out.
Yeah. Great. Well, there's no more questions. Would anybody like to share their experience at Stanford, and kind of as Sarah asked, anybody feeling brave enough to share what our experiences of their experience at Stanford? I feel like there's lots of different learning communities going on, and you might get a bunch of different answers. If there's anybody who would like to share.
I think one thing I'm really curious about was, as I read the Health Foundation survey, was whether it's reflective of your experience at Stanford. And I know that's probably a broad overgeneralization to try to, cram all of Stanford's various experiences into that one chart. But I'm just curious if things, would lack of capacity top the list? Are the same challenges experienced, lack of capacity, lack of financial support, things like that?
I feel like Lisa Freeman would be a good one. I don't want to put her on the spot, but I do feel like the Stanford, this center is really, addressing a lot of the challenges I think that would have been identified in our report. But Lisa, would you care to comment on how we align?
I think even as early as this morning, I was reaching out to people at both or among Stanford Medicine. You have the children's side, you have Tri-Valley, you have Stanford Partners, and you have the adult system. And all four have slightly different organizational priorities. I mean, a lot the same, like quality would be the same, engagement and employee wellness, things like that. But, there's just when they diverge a little bit, it kind of takes the emphasis off. Trying to get everybody aligned around one thing is challenging. I was more thinking about Dr. Richard Jordan is on the call here with me, who is a leader coach for the VA as they've been on their 4th or 5th year of trying to, they've been on this high reliability organization journey, and it's just a daily struggle because every time you get a new leader, and if you don't know what, just to take that as an example of what high reliability is, and then to say, oh, this is important. And oh, by the way, there's a huge change management component that goes along with that. It's just constantly pushing that rock up that hill.
Right.
So I'm really eager to share this toolkit with all the folks in our advanced course, different opinion leaders, thought leaders at the adult and children's side, and then also with the VA. It'll be really helpful for us. So, glad to know about, and I love the the interaction with other institutions that you welcome. But I would agree that just, the bandwidth of individuals and organizations to rally around one thing is limited.
Yeah, Lisa, this is Dr. Jordan. I hope you can hear me. I think, I want to share this with one of the centers or systems, VA systems that I'm working with in Eastern Colorado. It's very progressive, and they have a very progressive leader. And so, Sarah, I dropped a question, if we can get your presentation with the links, because I'd really like to work with their team to organize a constant learning sort of system, and I'm trying to work with them to print a paper about some of the things that they've done that I think would be beneficial to spread. So it's a great discussion.
Thank you.
And yeah, for everybody, just we do put with Sarah's permission, we'll put her talk on our website and with the slides with her permission, so everybody can access those later.
And thank you, Lisa. And thank you as well, Richard. I'll be happy to share those as well.
Well, great. Well, it's 12:50. So if you need to go, feel free to. If there's any more questions, I think if Sarah is able to hang on, then we can. Otherwise, thank you all so much. And thank you, Sarah, again, for a wonderful presentation.
Oh, thank you so much. I so appreciate your time today. I really do. And it was wonderful to be able to come and present for you all.
Thank you, everyone.
Thanks, everyone.